Today's we'll talk about syncope and we'll also try to cover the vertigo as well. So let's start with the syncope first. Syncope basically is a transient loss of functions of global loss of function of the brain stem and both the cortices due to the reduced blood supply. This is not ischemia. This is just a hypoperfusion for a very brief time and the patient loses consciousness. Remember, syncope by all means lasts only for seconds. So patient loses consciousness and the duration of that unconscious episode is not in minutes, it's in seconds, like 60 seconds, 30 seconds, 40 seconds, 10 seconds, 5 seconds, and then the patient becomes conscious. So this is syncope. Compare it, compare the syncope with the seizures, with the epileptic fits. Okay. Seizures, they never finish in seconds. They always extend in minutes. So if the patient was unconscious for in minutes, for few minutes, 4, 5, 10, 15 minutes, this is not syncope, this is seizures, this is epilepsy. Okay. But if the patient regained consciousness within seconds, up to 60 seconds, within a minute, within 1 minute, this is syncope. Syncope finishes in seconds and seizures, they lost in minutes. Seizures is never abolished within minutes, within seconds, okay? So this is one of the main clues. So whenever you see a patient who says patient has a state of unconsciousness, always try to quantify the duration. Syncope would not be lasting for minutes. Any unconsciousness which was there for many minutes is not syncope, is most likely seizures or something else. So that is which you need to know about how to okay. So syncope versus seizures. Syncope lost only in seconds, and seizures they never abolish in seconds. They always go and extend in many minutes. So if the patient was unconscious for many minutes, this is not syncope, this is seizures. If the patient regained consciousness within seconds, 5, 10, 15, 20, 30, 40, 50 seconds, that was syncope. This is very important to differentiate. Are you dealing with the syncope? Are you dealing with the seizures? Sometimes syncopal episode can end up in seizures-like episode because of that hypoperfusion can trigger the abnormal firing of the neuron, and that's called a syncopal seizures. That is different story, but usually the syncope would last only in seconds. So this is the first thing. How to approach on the bedside or in the outpatient for a patient who present with the syncopal episodes? It remember the most important clue is which will help you to find out what's the cause of the syncope is to find the associated clues or the circumstances when that syncope actually happened. Okay, so the main thing is the circumstances when the syncope happens. Those circumstances are the most important thing. Okay, before I go into the detail of those circumstances, which will help us to differentiate what's a syncope, what's the cause of the syncope, let's we need to be very sure that what the patient means by the syncopal episode. Sometimes the patient will say, can say, even if they have a dizziness, they have a vertigo. Okay, so the patient will say, I had a dizziness. So dizziness is a presenting symptom of the patient. Patient will not say that I had a syncope. Patient will present with the dizziness. Okay. And it's us who need to elaborate what the patient mean by the dizziness. Ask the patient, is it a spinning feeling? If it's a spinning feeling, that's a vertigo. If it is like a fainting episode, okay, like I'm going to faint, I'm going to collapse, or the patient actually, this is pre-syncopal. And if the patient actually loses the consciousness and regains the consciousness within a minute, within few seconds, that is a syncope. If the patient remains unconscious for minutes, this is not syncope, this is epilepsy. So the circumstances which help us to find out the cause of the syncope, they are the most important, which we need to elaborate. And remember, patient with epilepsy, they will have a post-ictal phase and they will not remember anything during the episode, what happened during the episode. Okay. Whereas the patient with the syncope, they can often recall the preceding circumstances when which led to the syncopal episode. So is the patient will be able to inform you about what were the circumstances which led to these episodes. Okay. So the first thing you ask the patient is about when it happened, what triggered the dizziness, what triggered the syncopal episodes, right? So let's specify those things. So syncope, which comes on exertion. There's two types of the syncope. One is syncope when the patient just stood up. Patient says, "I just stood up and I felt dizzy. I felt lightheaded and I was about to collapse and I sat down." That was a pre-syncopal episode. This is a postural syncope. The second is the second type of the uh, syncope during the activity is that the patient stood up. He didn't feel those symptoms immediately, but during that exertion, for example, after walking a few minutes, the patient started having those episodes, syncopal episodes. Okay, so that is exertional syncope. So exertional syncope is different from the postural syncope, but both of these they come during the standing. So patient was standing and patient had a syncopal episode. So you ask the patient for how long you have been standing before you had this episode. If it happens immediately, the patient says, the moment I stood up, I started feeling dizzy. That is a postural syncope. If the patient says, no, I stood up fine, when I started walking or running, during that process, or when I started jogging or cycling, then I started feeling dizzy. So that is a exertional syncope. So you need to be very clear what is exertional syncope and how to differentiate it from the postural syncope. The causes of the exertional syncope mean are the one which which impairs the increment in the cardiac output. If there's any reason which leads to reduced cardiac output during the exertion, that can lead to syncope because of the reduced blood flow to the brain. For example, patient has obstructive pathology which is leading to the reduced blood flow in the lungs or through the heart. Patient has a mitral stenosis. Patient has a severe aortic stenosis. Patient has a severe pulmonary stenosis. In those cases, the blood flow and the cardiac output cannot be increased even during the exertion. So the patient will get exertional syncope. This is one thing, obstructively. Similarly, the patients who have multiple PEs or a significant size PE, or the patient who has a pulmonary hypertension, they will also have a exertional syncope because they cannot augment, they cannot increment the cardiac output when the demand is high. So if the syncope, this is one side of the story, that there is obstructive lesion either in the pulmonary vessels or in the cardiac valves, and the cardiac output cannot be increased. Okay, and during the exertion. Second is there's no obstructive lesion, the valves are okay, there's no pulmonary hypertension, but the heart cannot increase the heart rate. So patient can't have increase in the heart rate to augment the cardiac output during the exertion. For example, patient has heart blocks. Patient has defective conduction system of the heart. So those patients who are on the rate control medication, beta blocker or calcium channel blocker or digoxin. These are the patients who cannot increase their heart rate during the exertion. So they will have syncope because they cannot increase the cardiac output. So one is the obstructive cardiovascular lesions in the form of valvular lesions or in the form of pulmonary vasculature obstructions such as pulmonary hypertension or PEs. Second is failure to increase the heart rate during the exertion. That will also cause exertional syncope. Okay. And the third is during the exertion, patient actually gets ischemic cardiac events. Okay. For example, patient gets angina and patient gets dizzy spell or the syncopal episodes. So exertional angina or ischemic heart disease, which will impair the cardiac contractility, will also get the exertional syncope. Similarly, the patient who have a reduced cardiac output because of the pre-existing heart failure, right? So they can augment their cardiac output during exertion. So they will have exertional syncope. So exertional syncope have four main categories. Patient either has ischemic heart disease, which led to exertion-related ischemia and syncope. Okay, this is one thing. Patient may not have chest pain. Okay, the absence of the chest pain doesn't exclude exertional angina causing exertional syncope. This is a very important message. Second is an obstructive cardiovascular lesion in the form of mitral stenosis, tricuspid stenosis, pulmonary stenosis, or aortic stenosis. Third is obstructive lesions in the pulmonary circulation, such as pulmonary hypertension or patient with the PEs, multiple or severe significant size pulmonary embolism. Okay. And the fourth is the patient who has impaired conduction exertion. They may have enough heart rate when they are at rest, but their heart rate cannot be increased during the exertion because of the defective AV node or SA node, or because of the conduction. Okay, so because of the conduction defect, so they will have exertional syncope. So this is one. Next is the postural syncope. The patient says, the moment I stand up, I start feeling dizzy, I start feeling blackout, and I have to sit down. Or if I don't sit down, I lose the consciousness. Sometimes the patient may have a fall. If the patient doesn't sit down immediately, patient may have a fall, but the moment they are on the ground, they will be conscious. So they were standing up, they lost the consciousness, and the moment they fell down, they regained the consciousness. So this is a postural syncope. It usually happens due to any cause which causes postural hypotension. For example, patient is on vasodilator drugs, amlodipine, calcium channel blockers, ACE inhibitors, uh, angiotensin receptor blockers, which cause vasodilatation. Any vasodilators can cause postural syncope. Or the patient who have hypovolemia, patient has a significant nausea, vomiting, or diarrhea, patient has a reduced intake, so the patient can have a postural syncope. So the postural syncope is either hypovolemia, dehydration, or is because of the drugs causing vasodilatation. Sometimes this could be a clue for the autonomic neuropathy, because when we stand up, the autonomic nerves maintain the vascular tone and they maintain the blood pressure. So impaired autonomic nervous system will also cause postural syncope, such as the patient with the Port's disease, postural orthostatic tachycardia syndrome, or the patient who have autonomic dysfunction, they also have a postural syncope. Remember, postural syncope from the how to differentiate it from the exertional syncope, they have a different causes. Then the other circumstances which can cause syncope is a syncope on using the arms. If the patient says, I feel syncope using right arm or the left arm, this is subclavian steal syndrome unless proven otherwise. So syncope which comes on using upper arm, right or left, that is a subclavian steal syndrome, because that is subclavian artery is stealing the blood from the vertebral circulation, and the brainstem is not getting enough blood because the arm's blood flow has increased at the cost of the brainstem blood flow, and the patient start feeling dizzy, and patient actually can faint and pass out. So syncope which comes on using the right or the left arm is a subclavian steal syndrome, which can be congenital or which can be acquired atherosclerotic narrowing. Okay, right. Syncope which comes at bending, when you bend down. Okay, right. That will that really means they either the patient has problem in the thoracic outlet, because when we bend down, the thoracic outlet gets narrow, right? So that can cause syncope, right? Okay, syncope which then there's a syncope which comes with the neck movements. Whenever the patient turns the neck on the either side or the flexes the neck, the patient gets syncope, right? This is usually vertebrobasilar insufficiency. The problem is in the vertebral artery or in the carotid arteries. Okay, and whenever the patient turns the neck, the already pre-existing narrowing may get augmented, and that can cause syncope. Okay. Similarly, when we flex the neck, we are basically narrowing the thoracic inlet. You can try on your own. When you flex your neck, you can feel that the thoracic inlet gets narrow. So thoracic inlet obstruction, which is also called as thoracic outlet obstruction, okay, where the structures are entering from the neck to the thorax. Okay? If there's a narrowing there, for example, patient has a retrosternal goiter, or patient has a mass in the anterior mediastinum or superior mediastinum, which is causing compression there. Okay, and that can cause syncope during when the patient flexes the neck. Okay, so also the syncope during the neck movement can be a problem with the C spine. One is a problem with the vertebral or the carotid circulation in the neck. Second is a thoracic inlet obstruction, or the third is problem with the C spine, compressing on either on the vertebral circulation or compressing either on the cervical spine. Okay, cervical spinal cord. So that can also cause syncope. Okay. So syncope, which has relation with the, or there's narrowing in the vertebral or carotid circulation in the neck, or there's a thoracic inlet obstruction. Okay, carotid hypersensitivity can also manifest with the neck movement, especially when anything which will cause strangulation of the neck, for example, tight neck tie. Okay, that can compress on the that can press on the chemoreceptor zone in the carotid sinus, and that can cause syncope. Okay, now syncope which comes bending down. One was thoracic inlet, and second could be a patient with a raised intracranial pressure. Okay, right. Now there is a syncope patient who gets syncope in a condition whenever you increase the vagal tone. That's called as a vaso-vagal syncope. Okay. Any situation which activate the parasympathetic system can cause syncope. Okay. And one of those is micturition related syncope, because the bladder contractility is related with the parasympathetic activation, and that can also stimulate the vagus nerve, causing bradycardia and reduced cardiac output. Similarly, defecation syncope. Patient can get syncope with the cough or bending syncope. So these are special types of this syncope which are there because of the increased vagal tone. Then there's a vasovagal syncope that usually happens in the patient in the patient who are standing for a long time, for a few minutes in hot weather, and they don't have enough fluid intake. So that is basically a combination of postural element plus cardio inhibitory effect of the vagal tone and reduced cardiac output, and that causes syncope. That is very common, vasovagal syncope. That commonly happens in patients who are standing for long, especially in hot weather, and they can get the syncope. Okay. Now, these are the few types of the syncope which have a known circumstances. For example, patient has a syncope just on the standing with a postural hypotension. During exertion is exertional syncope. Patient syncope related to the neck movements is as something wrong with the carotid or the vertebral artery or the C spine or the thoracic inlet or the carotid sinus in the neck. Okay. Then the syncope which comes with the vagal stimulation. Then the syncope which is a vasovagal in pattern. Okay. Right. Then if the patient doesn't have the syncope, any definitive preceding circumstances which can explain the syncope, this is one scenario that we have excluded all these causes of the syncopal episodes, and we have excluded all these causes of syncopal episode, and still the patient has we didn't find the cause of the syncope. Okay, so that is if that is syncope of unknown origin, we fail to find any circumstances which can explain the syncopal episode. This is one thing. Second is, if the patient has a syncope while resting in the bed, while sitting, or when the patient was lying, patient is not standing and patient was not lying, and the patient has a syncope, or the patient has a risk factor for cardiovascular disease, or the patient has a risk factor for the brain disease. For example, patient is old age, patient has atherosclerotic disease, patient MIs and heart failures, and this patient is at risk of arrhythmias. Okay, or the patient has stroke in the past and is a risk factor, has a is at a risk of TIAs of the posterior circulation. Okay, so these types of the patients, even if they have circumstances which can explain the syncope, we still need to make sure this is not a cardiac or the neurological syncope. Okay, so the patients who have unexplained syncope, where patient who has unexplained syncope, where the circumstances are not able to help you. Okay, you should always make sure this is not a cardiac or the neurological. Second, those patients who get the syncope while they're in the bed, they're not standing, they're just lying down in the bed. Syncope at rest or syncope in the bed when patient is lying is should always be worked up properly to make sure it's not cardiac arrhythmia or it's not posterior circulation syncope. Okay. And thirdly, those patients who have a risk factor for the heart disease or the risk factor for the stroke, that syncope also is uh, need a workup. So if I summarize again, syncope during standing, when the patient just stood up, is a postural syncope, and the most likely cause is a vasodilatation or hypovolemia. If these are not there, then it's autonomic neuropathy. Then the syncope during the exertion is either there's reduced blood flow at any level. For example, patient has a stenotic valve lesions, mitral stenosis, aortic stenosis, pulmonary stenosis, or the patient has a reduced blood flow in the pulmonary circulation, such as pulmonary hypertension or pulmonary vasculature disease, or multiple Ps, or significant pulmonary embolism, right? Or the patient has defective conduction system and the patient fails to increase his cardiac heart rate during the exertion, and the patient goes into the syncopal episode. Or the patient is ischemic heart disease which gets triggered during exertion and patient gets cardiac arrhythmia causing syncope. So exertional syncope is always cardiorespiratory, and that workup is needed. Postural syncope is related to the vasodilatation or the autonomic nervous system most of the time. Syncope with the arm use is most likely subclavian steal syndrome. Syncope, which is related to the neck movements, okay, is either the problem with the vertebral and the carotid circulation in the neck, or problem with the C-spine, or problem with the thoracic inlet. Okay, syncope which comes in the circumstances which increases the vagal tone. Those syncope are basically types of the vaso-vagal. Okay, right. So and if we fail to identify the circumstances which can explain, or the syncope happens at rest when the patient is lying in the bed, or the patient has a risk factor for the heart disease, or the brainstem is ischemia, then we need to make sure this is not a cardiac or the neurological syncope, and patient needs a workup. So this is about the syncope. The second thing of course, depending upon your clinical impression, then you do the clinical assessment and the detailed workup. Okay. Now, the second thing we wanted to discuss was the vertigo. Vertigo is a basically spinning feeling. Remember how the body maintains a balance. Okay, this is basically a problem with the system, with the body system which maintains the body balance. Okay, so that especially during when we are turning around. But remember, the balance is of two types. One is when you're walking straight. Okay, the second is when the body or the neck or the head or the eyes are turning. Okay, that sort of the balance during the turning position is mainly managed by your inner ear. Okay, vestibular system in the inner ear, and the vestibular nuclei in the brainstem in association with the cerebellum. Okay, so inner ear is the main player which sends the messages through the vestibulocochlear nerve to the vestibular nuclei in the brainstem at the junction of the medulla and the pons, and that is coordinated by the cerebellum. Remember, the vestibular nuclei also has connection with the cortex through the thalamus. Okay, so these are the main anatomical locations which can explain the vertigo. So the vertigo can either be peripheral, which is problem in the inner ear, or the vestibular nerve. It can be central. Central means the problem in the brainstem where the vestibular nuclei are, problem in the cerebellum, problem or in the connections of vestibular nuclei with the cortex, such as through the thalamus. Okay, so first of all, we need to differentiate: is it a peripheral or is it a central vertigo? This is the most important query which we often deal in patients who present with the vertigo. Okay, remember, patient would often say, "Doctor, I feel dizzy." So patient would present with the dizziness. It's us who will differentiate: is it a syncope or is a vertigo? So if the patient says it's a spinning feeling, either the patient is spinning or the things in the room they are spinning, then it's most likely a vertigo. Okay. Sorry, I think there was a connection problem again. So patient would say present with the dizziness, and we need to differentiate is it syncope vertigo. So when we are sure this is a vertigo, okay, we need to differentiate is it a peripheral vertigo or is a central cause. Remember the peripheral vertigo, the most important clue for the peripheral vertigo is that it needs a stimulus, okay, because the cochlear nerves, the vestibular nerve and the vestibular system of the inner ear need a stimulus to send a message to the brain, okay. So the peripheral vertigo is basically stimulus related vertigo. So there need to be stimulus. For example, as I said, there are two types of the balance. One is when you're walking straight, that is not controlled with the vestibular system. The vestibular system usually control the balance when the body or the neck or the head or the eyes are turning. When any part of your body is turning, okay, is rotating or turning, that's where the vestibular cochlear system comes into play for to maintain the balance. Okay. So the peripheral vertigo, which is due to the vestibular system in the inner ear, would need a stimulus. So that stimulus comes only when the body turns. Okay. So the patient will feel vertigo. Sorry, I think there's a repeated problem with the internet today. Right. So peripheral peripheral vertigo needs a stimulus. So either it will be triggered by neck movement or the head movements or the eye movements or the body as a whole. Okay. So if the patient is not moving, the peripheral vertigo will usually settle down. Either it will completely disappear or it will significantly reduce in the severity. So one clue for the peripheral vertigo is a triggered associated with the movements, with the turning movements of the head, neck, eyes, or the body. Patient would say, whenever I turn my head, I start feeling dizzy. Whenever I start look at whenever my eyes move, I start feeling dizzy. Okay. Whenever I turn my neck, I start feeling dizzy, vertigo. And whenever I turn in the bed, roll over in the bed, I feel dizzy. Okay, this is the first thing. Okay. Whereas the central vertigo doesn't need a stimulus. Central system, the central vestibular nuclei and the brainstem, they are like a computer. The vestibular nerve is like a peripheral input to the computer, and the computer generates message based on the peripheral information. But if the computer itself is at fault, it can generate the messages on its own. So the central vertigo doesn't get better even if the patient is not moving. It's always there, it persists. Okay, it doesn't goes away completely. So if a vertigo goes away completely when the patient is still lying in the bed, not moving at all, with the eyes closed, neck still, head still, and body still, not moving at all, and the vertigo disappears, this is most likely the peripheral one. And the moment the patient start moving neck or the head or the body, the vertigo reappears. This is a peripheral vertigo because it's driven by the stimulus. Whereas the central vertigo is not stimulus driven. Okay, that usually continues without any stimulus. So the patients keep feeling spinning feeling, even if the patient's eyes are closed, patient neck is still, and patient is also still and is not moving at all. So vertigo which persists despite no trigger is usually a central vertigo. This is the first and the most important differentiating point, which should help you to think is it a peripheral vertigo or is it a central vertigo. The second important clue is, remember, the message from the peripheral nerves, from the vestibular nerves to the brainstem is transmitted by the neurotransmitters. Okay, and the more you stimulate the peripheral nerve, the more neurotransmitter are released. Ultimately, it comes to a point that the nerve terminals, they become depleted of the neurotransmitters. So there's a depletion of the neurotransmitter with repeated use. So ultimately what happens is that the stimulus would fade away. So the peripheral vertigo usually fades away after a few hours or at the most for a few days. Any vertigo which is not fading away after a few days or which is persistent without any reduction in the intensity is central unless proven otherwise. So this is the second clue. This is called as a fatigability. Okay, so if the vertigo has a fatigability, it means it disappears after this intense to begin with, is very intense, and then after with the passage of the time, it starts fading away. This is peripheral vertigo. Okay, but if it stays at the same intensity without any fatigability, even after a few days, then it's not peripheral, it's a central vertigo unless proven otherwise. These are the two most important clues which you should keep in mind differentiating peripheral from the central vertigo, because remember, even if the patient has an underlying reason to have a peripheral vertigo, still the patient can have a superadded central vertigo. So that's why it's very important to have a high degree of suspicion to think about the central vertigo and not to miss the central causes. Okay, so one is the vertigo stimulus drive. Stimulus is neck movement, turning the neck, head movement, turning the head, or body movement, turning the body on one side or the other side. Okay, so that is one. Second, is there any fatigability? Does it fade away within few hours or it stays at the same intensity? If it stays at the same intensity, this is central unless proven otherwise. The third important clue is presence of any associated signs of the brainstem or the cerebellar disease. Okay, for example, remember the brainstem has few structures. One is the descending motor tracts, which comes from the cortex and goes to the spinal cord. They pass through the brainstem. Brainstem also has ascending sensory fibers, which comes from the periphery, such as pain fibers through the spinothalamic tract, and the position and vibration fiber through the dorsal column tract. They ascend through the brainstem. Okay. Then the cranial nerves nuclei are present in the brainstem. Then the cerebellar nuclei, cerebellar spice, olivary nucleus is present in the brainstem. Cerebellum has connection with the brainstem. So remember, whenever there's a pathology in the brainstem affecting the vestibular nuclei, causing vertigo, there's a likely possibility that the other structures in the brain or next to the brain, such as cerebellum, may also be affected by the same pathology. If you look at the brain in the live, the thickness of the whole brainstem is not more than my finger, my index finger. Okay, you can see that. Now, this is the whole thickness of the brainstem. You cut it in this finger into two in vertically, lengthwise. This will be the right half and the left half, right brainstem and the left brainstem. And then you cut it further to make it like medial and lateral. So remember what will be the total width of the brainstem, okay, where all these structures are densely packed. So even a single drop of blood or a blockage of a small capillary in the brainstem may be enough to damage many of these structures. Okay, so usually if the vertigo is a central one, a central cause, often, I'm saying often, not always. Okay, often there will be associated clues for the brainstem pathology. Such patient may have a cranial nerve deficit, third, seventh, 9, 10, 11, whichever, depending upon the location of the brainstem involved, or the patient may have a cerebellar signs as well, nystagmus and dysdiadochokinesia, okay, or impaired finger nose test. Remember, cerebellum and the brainstem, they share many things. One of them is a blood supply. Blood supply of the cerebellum and blood supply of the brainstem is shared. Okay. Secondly, so if it's a vascular disease, it often involves both. Okay. Brainstem as well as the cerebellum. Secondly, they are densely packed in a small posterior cranial fossa. So space occupying lesions will also affect both of these. So space occupying lesions or the vascular pathologies often involve the cerebellum and the brainstem together. So it's not uncommon to have cerebellar signs in a patient who get a central vertigo. Okay, because the cerebellum and brainstem, they're very close. They share the blood supply, and also all the input and output of the cerebellum, they pass through the brainstem. superior peduncle, middle peduncle, and inferior cerebellar peduncle, their fibers, they pass through the brainstem. Similarly, the main spice of the cerebellum is the olivary nucleus in the brainstem, in the medulla. Okay, so any disease which will affect with the brainstem will also affect the cerebellum as well. So if it's a central vertigo, patient may have a cerebellar signs, patient may have a brainstem signs in the form of motor weakness, hemiparesis, hemiplegia, upgoing plantar, or sensory deficit, hemianesthesia on one side, or patient may have a cranial neuropathy, cranial nerve disease as well, or combination of these things. Sometimes these signs are not there even if the brainstem is involved. Okay, either the lesion is very micro infarct, which just affect the vestibular nuclei, okay, or there's a tiny granuloma in the vestibular nuclei, or there's a loss of connection of the vestibular nuclei with the thalamus and the cortex. Okay, so in that case the brainstem itself will be normal because the pathology is not in the brainstem. If the pathology is in the thalamus, because the vestibular nuclei are connected to the cortex through the thalami, so if there's a thalamic infarct or if there's a thalamic lesion or damage to the thalamus, that can cause vertigo as well, even if the vestibular nuclei and the brainstem are structurally normal. So we don't always find the brainstem abnormality either on examination or on imaging in patient with the central vertigo, because it could be due to the loss of the central connections of the vestibular nuclei, which are linked to the thalamus and then to the cortex. Okay, this is right. This is the third important clue. So important clue is there any stimulus which drives the vertigo? Second, is there any fatigability? Third, are there any brainstem signs or the cerebellar signs? Okay. The fourth important thing is, does the patient have history of any ear related problem? Patient has deafness, patient has tinnitus, patient has ear discharge or ear ache, or any disease related to the ear can cause vertigo. Remember one very important clue, that the middle ear opens in the oropharynx through the Eustachian tube, and it has a very tiny tube which connects your middle ear with the oropharynx, and it has an opening in the oropharynx. Any swelling, any tiny secretions in the oropharynx, okay, any phlegm in the oropharynx or inflammation in the oropharynx can block the Eustachian tube and can cause high pressure in the in the middle ear, and that can irritate the inner ear and can cause vertigo as well. Okay, so if there are symptoms related to the inner ear, okay, so that may indicate that the patient has a peripheral vertigo. But remember, for example, patient has a chronic ear disease, right? A patient has a deafness and tinnitus as well. That doesn't exclude that the patient can't have a central cause of the vertigo, or patient can't have a TIA, or patient can't have a stroke. So any patient who has a high risk factor for the stroke or for the brain disease, even if the patient has peripheral disease in the inner ear or the vestibular nerve, even then you need to make sure this is not the central cause, and we're not missing the central causes, because the central causes are more sinister. Missing a peripheral cause of the vertigo is is not going to kill the patient, but missing a brainstem ischemia, patient may die. Okay, so this is very important to think of the central vertigo. The fifth important clue is of the central vertigo is that central vertigo often doesn't respond to antihistamines or uh, the vestibular sedatives, because remember the connection of the vestibular system, the inner ear, to the vestibular nuclei is connected through the vestibular nerve, and as a neurotransmitter, histamine is the main neurotransmitter which works on H1, histamine 1 type of the receptors on the vestibular nuclei. And that's why if the message is coming from the peripheral system, from the inner ear, you can block it, you can reduce it by using antihistamines. So that's where the peripheral vertigo often responds to antihistamines, whereas the central vertigo starts after those receptors. Receptors are the histamine is released from the vestibular nerve, and it stimulates the vestibular nuclei. That's it. Histamine has no role beyond that point. Okay, so histamine has no active role in within the vestibular nuclei or the connection of the vestibular nuclei with the cerebellum or with the thalamus. So antihistamine, they don't work well for the central type of the vertigo. So if the vertigo is not responding to antihistamines adequately or there's no response at all, that also may be a clue that we should think about the central vertigo. Okay, so these are the five main things. Now, next important clue is vertigo with nystagmus. Vertigo with nystagmus is central unless proven otherwise. Okay, remember this as a statement. Remember this: vertigo with nystagmus is central unless proven otherwise. Okay, and remember there are three types. Nystagmus is a eye movement. Tremors of the eyeball, they are called as nystagmus. Basically, they are tremors of the eyeball. Okay, horizontal nystagmus and vertical nystagmus and rotational nystagmus. There are three types of the nystagmus. Okay, peripheral causes, when they irritate the vestibular system. Remember, the vestibular system has a connection with your ocular system through the vestibulo-ocular reflex. Okay, VOR, vestibulo-ocular reflex, and this vestibular nuclei, they are connected with the oculomotor nerves and trochlear nerve and abducens nerve, which controls your eyes, through the medial longitudinal fasciculus. So medial longitudinal fasciculus is a short bundle of fibers, nerve fibers, which connect your eyes and ear within the brainstem. Okay, which connect the vestibular nuclei and connects the oculomotor, abducent, and trochlear nerve nuclei within the brainstem. Okay, so remember, uh, problem with this system, okay, will also can affect the position of the eyeballs. Okay, so this is vestibulo-ocular reflex. So most of the time, vestibular the vertigo is often has a nystagmus as well. And if there's a nystagmus as well, most likely this is a central one. The peripheral vestibular system, if it causes nystagmus, it usually causes horizontal or rotational nystagmus. Okay, but remember vertical nystagmus, the vertical nystagmus is always due to the vestibular nuclei in the brainstem. So vertical nystagmus, all right, when the eyeballs move up and down like this, they have a nystagmus rather than on the side, they go up and down. So vertical nystagmus is almost always to the vestibular nuclei in the brainstem. So patient who has a vertigo with nystagmus, especially if the nystagmus is vertical, this is brainstem or the central vertigo, uh, beyond any doubt. Okay, but if the patient has a horizontal nystagmus is also possible in the cerebellar disease, or is also possible sometime in the peripheral disease. But usually the semicircular canals, they usually cause rotational nystagmus rather than horizontal or vertical. They usually cause rotational nystagmus. Okay, depending upon which semicircular canal is involved, patient can have horizontal or the rotational nystagmus. But vertical nystagmus alone is not explained by the west inner ear. Okay, so any vertigo which is associated with the nystagmus, especially if it's a vertical nystagmus, is always brainstem. Similarly, if it's a horizontal nystagmus, it can be cerebellum, which again is a central, or it can be inner ear. Okay, so these are the clues which help you to differentiate, is it a peripheral vertigo or is a central vertigo. And the next important thing is, whenever you are in doubt, sometimes it's not as easy as it seems after my lecture. It's not that easy, but sometimes it's really confusing. It's very hard to say, is it a central or is it a peripheral? Remember, if the patient has any underlying predisposing condition which can cause central vertigo, for example, patient has risk factor for atherosclerotic disease, patient has diabetes, hypertension, history of smoking, patient is old age, patient has previous history of TIAs and strokes, or patient has history of cardioembolic disease, in those cases, take it as central unless proven otherwise. Again, if the patient has a risk factor for any neurological disease and the patient is presenting with the vertigo, take it as central unless proven otherwise, because missing the central vertigo can be disastrous. Okay, this is one thing. Or when you're not sure, you have done your best and you have eliminated the peripheral with all the certainty that this is not peripheral, take it as a central vertigo. So, right? So, before you label somebody as a peripheral vertigo, you have to ask yourself, are you 100% sure this is not central? So, patient doesn't have uh, any sustained vertigo. There's a definite fatigability. There's definite clues for the inner ear disease. There's no risk factor for the brain disease, and there are no brainstem or the cerebellar signs. Okay, in those cases, it could be a peripheral vertigo, but whenever you are in doubt and it's not clear, always take it as a central vertigo unless proven otherwise. Okay, so this about the this is about the vertigo. Okay, uh, so I think I'll stop here. If there's any question, I'm more than happy to take those questions. Any questions? Anybody who is not clear about vertigo or the syncopes? Important thing is you should be able to differentiate what is the difference between syncope and vertigo, and what is the difference between syncope and the seizures. All right, because patient would present with the dizziness, and dizziness can be vertigo, it can be syncope. Right, vertigo is mainly a spinning feeling. Syncope is like fainting or pre-fainting feeling, and the patient can actually lose the consciousness. And dizziness, syncope usually lasts in for seconds, and there's no post-ictal phase. Patient would regain consciousness within a minute. The moment the patient is on the ground, patient usually regains the consciousness. If the patient is unconscious for more than a minute, then it's beyond the syncope. Unless the patient has a syncopal seizures, that is a different story. Okay? The syncopal seizures will manifest that patient started with the syncope, and then patient has a seizure-like manifestation such as incontinence or tongue bite or limb jerking. Okay, and remember the seizures, they are usually followed by amnesia of variable duration, with uh, and post-ictal phase as well. But the syncope itself, without syncopal seizures, is not followed by the post-ictal seizures, and there's no amnesia. Okay, and usually finishes within within seconds. So syncope is for seconds, right? Sears loss in minutes, and then the Sears also has a post-ictal phase. Okay, and the main diagnosis of the syncope depends upon the preceding circumstances and which circumstances the patient felt syncopal. If the patient feels syncopal while lying in the bed, take it cardiac or neurogenic unless proven otherwise. If the patient has cardiovascular risk factors or the risk factor for the brain disease and start having syncope, take it as cardiac or neurological unless proven otherwise. But if the syncope comes only at standing, immediately after standing, this is postural syncope due to the vasodilatation or autonomic neuropathy or hypovolemia, dehydration. Syncope, which doesn't immediately start while standing, but starts up once in the during the exertion, then there's a cardiac or cardiovascular syncope, uh, especially the cardiac right heart, left heart, or the pulmonary circulation, unless proven otherwise. Okay, syncope which comes with the right or left arm use is a subclavian syndrome, unless proven otherwise. So syncope which comes with the neck movements. Similarly, you look at the vessels in the neck, you look at the cervical spine, and you look at the thoracic inlet. Okay? And syncope, which comes standing for a while, in the hot weather, sweating, dehydration, that's a vaso-vagal. Okay, that's very common. And the syncope, which happens because of the vagal stimulation during micturition or defecation or cough, that is usually uh, because of the vagus induced bradycardia. Okay, syncope which happens due to cough or bending or sneezing could be because of the raised intracranial pressure, or could be because of uh, thoracic thoracic inlet. Now, sometimes the patient gets neurogenic syncope, the syncope within the brainstem. Okay, the patient has either TIA. Often they get a TIA and they get syncopal. TIA is over, and TIA can of the posterior circulation can be confused with the syncopal episodes, especially if the TIA was very brief. Okay, that can confuse with the syncope. Okay, right. Rarely, patient has a midline tumor, midline meningioma or a tumor in the falx cerebri, and that is hanging in the middle between the two cortexes, where there is, and it can sometimes block the openings of foramina Monro, which this is the foramina which connect the third ventricle with the which connect the lateral ventricle with the third ventricle. Okay, and that can cause syncopal episodes as well. Okay, but that will be very postural. All right. And vertigo, the main thing is it a peripheral or not? First, you differentiate vertigo from the syncope, and then differentiate is it a peripheral or not. Peripheral is usually stimulus derived. There's some stimulus, there's neck movement or head movement or the body movement as which triggers, and it usually abolishes either completely or significantly when the patient is not moving at all. Okay. Second is it has a fatigability. The peripheral one has a fatigability. The peripheral one may have a ear-related problem as well. If this is not there, then central vertigo has no fatigability. It's not trigger stimulated. It's continuous. It's persistent. It may have a brainstem signs or cerebellar signs, and the patient may have a cardiovascular or risk factor for the neurological disease as well. Okay. If you are not sure, take it as a central vertigo unless proven otherwise. And that unless proven otherwise mean we have done the enough, such as MRI of the brainstem, to make sure there's nothing wrong in the brainstem. All right. Now that I'll stop here. If there are any questions, I'm more than happy to take the questions. Anybody has any questions? No question? Then can we finish then?